All right, good morning, everyone, or good afternoon, depending on when you are joining or watching us. I'm Heather Roscoe. I'm the clinical manager with Montana Family Planning, if you're not familiar with who I am. And today, we appreciate you joining our quarterly clinical conference call on syphilis and syphilis serology. We have a guest speaker with us today, Tammy Bennett, who I will introduce a little later. Just some housekeeping items I want to review before we start. So this is a 2-hour webinar that we've planned, and we do have about a 5-minute break about halfway through. So we'll get a chance to get up, move around, and do whatever you might need to do at that time. But we'd love to have you turn on your cameras if you're willing and able to, or have one so that we can see you during this presentation. That would be super fantastic. And we'll also do our best to keep you engaged during the presentation by asking any questions, utilizing the chat, and there'll be some poll questions that you'll see as well. And then if you're attending this later, feel free to maybe have a notepad or jot these things down, or just think through these questions that we have as you move your way through the presentation. Feel free to type any questions that you might have into the chat, and we will do our best to address them during the presentation, but know that we will also have a Q&A session planned as we wrap up. So before we get started, we must acknowledge, oh, Tammy, can you go back one of the acknowledgements? There we go. Perfect. So our acknowledgements for this training is it's supported by funding from the Office of Population Affairs through the Department of Health and Human Services, which funds our program, as well as the Clinical Training Center for Sexual and Reproductive Health, who is supporting this training. The opinions expressed and are the views of the contributors and do not necessarily reflect the official position of HHS, OPA, or the Clinical Training Center for Sexual and Reproductive Health. Next slide. And then the nursing disclosures. So this nursing continuing professional development activity was approved by Montana Nurses Association, an accredited approver with distinction by the American Nurses Credentialing Centers Commission on Accreditation. The total nursing contact hours are 2, and in order to receive your nursing contact hours, you must attend the entire activity and submit the evaluation form at the end, identifying one intended practice change related to the management of syphilis. Nursing contact hours are available until September 28th, 2025 for this event. And then none of the planners or presenters for this educational activity have relevant financial relationships to disclose with ineligible companies. Great, so it's my pleasure to introduce our speaker today. Tammy Bennett began her work as a women's health nurse practitioner career 23 years ago. She's been working as the Title X regional nurse, overseeing 11 clinics performing Title X services, and as an APRN delivering Title X services for the last 7 years, being the Louisiana Reproductive Health statewide nurse consultant, overseeing all Title X services in Louisiana. She currently works with over 60 parish health units and 6 subrecipient clinics to provide quality family planning services. One of Tammy's passions is ensuring all persons have equitable access to quality FDA-approved methods of contraception and offering these methods using a client-centered approach. Another passion includes educating providers and clients on sexually transmitted infections, screening, appropriate treatment, and risk reduction strategies. Both passions have merged into Congruent Consultants Corporation, where she assists other organizations in incorporating sexual and reproductive healthcare into their practice. And Tammy wanted me to share her motto with you. And together we can provide quality sexual and reproductive health services, making a difference one client at a time. I love that. So before I turn it over to Tammy, I'd like to review some surveillance data with you all. And you all might be familiar with this information that's coming, but I think it's important just as a quick refresher. Next slide, great. So in 2012, 2 states, the District of Columbia and 1 U.S. territory had a rate of reported primary and secondary syphilis greater than or equal to 7.6 cases per 1,000 population. As you can see, this increased to 42 states, DC, and one territory in 2021. So this slide just goes to show that we're not alone in Montana seeing these increasing rates. Next slide. Montana surveillance data spans back to 1919 and has seen similar trends in increasing cases. I think it's interesting to see that the number of cases in 2022 were similar to the number of cases back in 1948. In 1928, this person discovered penicillin, and from 1943, it became the main treatment of syphilis. I'd love for you to type in the chat. Do you know who this person was who discovered penicillin? I'll give folks just a minute to think about it. Okay, I'll help you out. It was Alexander Fleming. Next slide. There we go. So the number of syphilis cases by all stages in Montana. So this is as of June 8th, 2023. Montana Department of Public Health and Human Services reported a total of 332 syphilis cases at all stages. Again, this graph just shows where cases are highest, and you'll note that some of these areas are also near or on reservations. So in 2021, the highest rates of reported primary and secondary syphilis cases were among American Indian and Alaskan Native persons, about 47%. During 2020 to 2021, the greatest increase in rate of reported primary and secondary syphilis cases were among American Indian and Alaskan Native persons, from about 27% to 47%, or about a 74% increase. American Indian and Alaska Native persons also had the greatest 5-year increase in rate of reported primary and secondary syphilis, so from about 11% to about 47%, which was about a 325% increase from 2017. So I think this slide is important when we think about health disparities and the population served. And while we consider equitable access to sexual and reproductive health care services important, as well as addressing trauma in historically underserved populations, these topic areas deserve their own discussion, one which we won't be covering today. Next, we'll look at congenital syphilis. So in 2012, 7 states had a rate of reported congenital syphilis greater than or equal to 16 cases per 1,000 live births. This increased to 41 states, DC, and 2 US territories in 2021. Again, we're not alone here in Montana of seeing increasing rates of congenital syphilis. And then in Montana specifically, you can see the number of cases have increased, with 1 reported case in 2019 and 11 cases reported so far this year. And this data is current as of just two weeks ago. Again, in looking at health disparities among race and ethnicity for congenital syphilis in 2021, the highest rate of reported cases of congenital syphilis per 1,000 live births was among mothers who were American Indian or Alaskan Native, who also experienced the greatest increase in rate of reported cases of congenital syphilis during 2020 to 2021, as well as the greatest 5-year increase in rate of congenital syphilis. So you can see this very similar trend in the data presented earlier in the rates of primary and secondary syphilis. I think it's also important to note that there were also no decreases in the rate of congenital syphilis among any race or ethnicity group from 2017 to 2021. So with that, I would like to turn it over to Tammy to start the rest of the presentation. Thanks, Tammy.
Thank you, Heather. Hello, everyone. I'm coming to you live from near the New Orleans, Louisiana area. I promise I will not throw any beads at you, but we're hopefully going to have a very interactive share time. And I hope that at the very end of this, you will not be afraid of syphilis. You will be ready to test everybody and then learn to interpret those results. That is my goal. with any of my talks, I really love questions. So you please feel free to put them in the question and answer, because if you have that question, I can promise you probably someone else does too. So with that, what is syphilis? Well, there's a quote by Sir William Osler that says, "He who knows syphilis knows medicine." And I think that all of us will agree, no one will ever know everything about medicine. And so syphilis is one of those things. It's also called the great imitator, and it can look and mimic other things so easily. And as we go through the presentation, I'm going to show you some pictures, and hopefully you can put it in the chat what some of these may resemble, like if you were to see them coming through the ER or dermatology clinic or even your Title 10 site. So again, it's called the great imitator. It can mimic rectal cancer, penile cancers, ulcerations, and also there's going to be some things where it looks like psoriasis, or even just a contact dermatitis if they have the rash. So as we go through, you're going to see it does have some similarities. So here's our first poll, and I will again want this to be interactive and fun, but let's see, how comfortable are you with syphilis labs, staging, treatment, and follow-up. And then we're going to discuss, why is accurate staging so important? So you should be able to answer this. Okay, so we've got some comfortable, some neutral, and some uncomfortable. So that's great. Let's dig in and let's see where we are at the very end. All right. So let's talk about, why is accurately staging syphilis so important? Does anybody have an idea? Anybody want to come off mute or put it in the chat?
For accurate treatment, and then also to
Absolutely.
make sure you're doing partner follow-up correctly too.
Absolutely. Yes. If it's not staged and treated appropriately, then the treatment is not going to fall where it needs to go. So yes, absolutely. So let's learn about the stages of syphilis. It starts with an infection, an event that leads the bacteria to come through the mucous membranes and infect the other partner. This can lay dormant for about 3 weeks to 3 months. And at the first stage that you really have symptoms is called the primary stage, where you get a primary ulcer. And then if you're not treated, that ulcer is going to heal on its own. And then you go into secondary. And then if you're not treated, it's going to go away on its own. And then you go into a latency phase, where during latency, there's no signs and symptoms. And the only way that you're going to know that a person has syphilis is by testing that person. And you can go into, the categories of, well, we're going to talk about each one of those: unknown, early, and late, and then tertiary. So let's dig into all of these. And I do have some pictures, but I know y'all are in the medical field and you can handle it over lunch. Here we go with primary syphilis. It starts with a single or multiple chancres, but most of the time it's a single chancre. The only time I have ever seen multiple chancres is when, like, the labia fold in on each other, and you can have what's called kissing chancres. And you can have this around the penis, the vagina, the anal area, rectum. You can have it inside the mouth or on the lip. You can also, I have seen it on the cervix. So because these are usually painless ulcerations, then sometimes they can go unnoticed. Um, Usually you only search for something if it's obviously visible, but it's not going to be visible usually if it's around the anal opening or um, um, near the cervix. The reason why it is not painful is because the bacteria Treponema pallidum puts out a numbing effect on the tissues. So when that's kind of like I guess, a good side effect to having a big ulcer. But on the other side, if you don't know if it's not hurting you, you may go ahead and miss it too. It is usually firm, round, and painless. And again, this is what it looks like typically. You have a rolled edge and a clean base. So it doesn't have a lot of purulent activity going on. This is what I was calling earlier the kissing chancres. It probably started in one area, and then because the labia folds in together, you can get one on the other side. We're going to skip this one for a moment. Again, this is just a classic look of a primary chancre here. Now this, if you were to see this come into your clinic, what would you think that was? And then his history is this just started about 2 weeks ago. You would wonder what kind of timeline 2 weeks is on, right? Because this looks like it's got to have been brewing for longer than 2 weeks. And I would think we're talking about some kind of penile cancer. What this is syphilis, primary chancre in a person living with HIV that is not in treatment. So you can see where it has a much more invasive sometimes presentation whenever the person is immunocompromised in any of their immunocompromised states. And you can also see where that can mimic, other things. If it goes untreated, then the primary chancre heals up on its own, and they just go along for 1 to 3 months and think everything's fine. And then all of a sudden they start breaking out into this rash. 90% of all people get the rash. It's a maculopapular pustular lesions, but it also, if you ever see a rash that involves the palms of the hands and the soles of the feet, let that be the blue light warning that something bigger is going on, that this is not a reaction to their detergent or their new soap. This is something bigger. Condyloma lata, we're going to go through all of these and I'll explain as they go through, but condyloma lata is not the same as genital warts. Condyloma lata looks like warts, but they always have a pinkish color and they're wet and they're very fast growing. I'll give you an example when we get there and tell you a story so you can remember that. Mucous membrane patches, that's kind of where you get those canker sores, in your mouth, or you can get some mucus patches. Because the Treponema pallidum bacteria is now more widely disseminated in the bloodstream, you're going to have more constitutional symptoms like the fever, tiredness, the sore throat, weight loss. It can also mimic like early HIV infection because you've got those constitutional symptoms. And then it can invade the central nervous system at any time during the syphilis journey. It doesn't have to be in secondary. It's not always in tertiary. It can happen at any time. So with the central nervous system, of course, if it invades that, that's a whole nother treatment algorithm that requires IV penicillin. And if you don't act on it quickly, if it does affect the eyes or the ears, they can lose their sight or their hearing. So we do want to make sure we're screening for neurosyphilis. Okay, here's some pictures. Again, anytime you have a rash on the palms of the hands and the soles of the feet, then let that be a big warning that something more is going on. This is just a disseminated rash. It's not itchy, but gosh, it looks like it's just miserable. But they just notice it. And a lot of times what we find in Louisiana, we've been battling syphilis for quite a while down here in Louisiana. And so they'll go to the dermatologist and they'll get a shot of Celestone and some cream, and miraculously in a week or so it goes away. Guess what? That wasn't the Celestone that was fixing it. It just naturally wears its course and goes away. So they still have syphilis and it's still active. That's what we have been trying to get the word out to all of our providers here about is looking at those hands and feet. Now, I don't want to say that it's mandatory to have that rash on the hands and the feet. I have seen a syphilitic rash just in the small of the back. I have just seen it on the lower trunk. So just when you think you know it all, another one will come in and just blow the water to you. So this is typical presentation, but there's always those outliers. This is what the rash looks like on persons of color. It can really sometimes look like some psoriasis going on. So don't let it fool you. If someone came in with this on their face, what would you think? Somebody unmute and just tell me what this looks like. Ringworm? What do y'all think? Yeah. This is actually what the beginning stages of what it will turn into be like this, which is called nickel and dime lesions. And actually, as soon as you give the penicillin, probably within a week or two, this is going to be completely resolved. So penicillin, Mr. Alexander is a hero. This is what we call condyloma lata. So the difference between, see how they're elevated lesions, they can look like genital warts, but the difference is that no matter what the skin color is, these are going to retain their pinkish, fleshy, colored appearance. They're also more wet and moist. You can see the reflection of just kind of the moisture here. Than typical genital warts. So think of pink and wet, and then what you'll find is in the history, they're going to tell you that this has popped up on them in the last couple weeks. And you're like, oh, that kind of just happened in a couple weeks. But you know what? It really does. And then as soon as you give that bicillin, it's usually gone in a couple weeks. So very, very rapid. If you were to scrape some sections of like this off and look under a dark field microscope, you would actually be able to see the coiled helical bacteria. Some other symptoms within secondary, because we were talking about it doing the dissemination throughout the whole body, you're going to get like the patchy alopecia, you're going to get lymphadenopathy, some of the time. Now, not all the time, but some of the time, and I have actually seen this as well. All right. So we go through secondary. No treatment. They think, oh, that Celestone works, didn't it? Well, it really didn't. Then they go into a latency phase where they can still possibly transmit this infection to someone else, but there's no active signs of it. So the only way to know is to actually test someone. Now, there's 3 possible stages. There's early latent, and that's the time that they're still considered infectious. But then there's late latent, and then there's unknown. So we're going to go through each one of these individually. What you're going to see me do is this thing with my hands. Do y'all see this? It kind of looks like a football goal. Okay, and it's not a football goal. I'm not a football fan. What this means is it is a time frame. It is a window of 1 year. Everything hinges on this 12 months, 365 days to determine if they're early or if they're in the late stage. So let's talk about that early time frame. If you see an infection and the symptoms have occurred within that last 12 months, then you can say they're early. If you have no symptoms at all right now, and you can pull like the last serology test and they had a documented negative within that last 12 months, then you know they're early. We're going to talk more about rising titers, but if they've ever had syphilis in the past, and you have the titer within a year and then you see a 4-fold increase within that year, you know they're early. And then if they've been a contact of syphilis or had their age at first sex was within a year, then you can go with that. and just use the treatment for early latent. Now, late latent is where when we pull the labs, it was over a year ago when they were negative, and so we cannot guarantee that they actually got this infection within the last year. You can also do uh, late latent whenever they have no past serology report, like you ask your friends in the health department to pull the data and there's nothing to go on. So we're going to go ahead and err on the safe side and do late latent with the series of 3 injections. All right. The one that has the no past serology results, it really falls into syphilis of unknown duration, because if we don't have any labs, it could have been within the last year. It could have been more than a year ago, but we're, like I said, going to err on the safe side of going ahead and treating with the 3. The syphilis of unknown duration and late latent are both reported the same in the is that Midas? Midas? One.
Yep, Midas.
Midas. Okay, good. Ours in Louisiana is actually called Prism. So Midas is yours that you use, but it's a database that holds all of the information. So and the reason why they're reported the same is because it's the same treatment and follow up for partners as well.
And
Okay.
I noticed the typo there, folks. It's just Midis. The one that you're familiar with is Midas.
I keep going with AS, didn't I?
Right, here we
I think that might be a tire. I'm not sure. But anyway, tertiary syphilis is a very slow progressive disease. So let's say that, latency can last for years, 250 to all the way to 50 years. And some people will develop tertiary syphilis and some will never develop it. We really don't know which ones it's going to be. Tertiary syphilis is not necessarily happens after X amount of years either. And some people, if they're going to get it, they might be able to start with these progressive disease issues, which we're going to go through here in a minute, in 2 years, whereas others, it might take them, 30 or 40 to get to. Um, what what you can get is, of course, with the neurosyphilis, with the optic neuritis and uveitis, and then when you do a spinal tap, whenever you send the fluid off to the lab, you will see a positive VDRL or RPR in that titer. For tertiary, you can also get aortic regurgitation or aortic aneurysm because this bacteria is affecting all of your internal organs. There's gummatous lesions where remember the penile ulceration that was so invasive, that could actually be called a gummatous lesion as well, and it may mimic a tumor on the penile shaft. You can also get these large rectal masses that look like rectal cancer, but in reality, it's the gummatous lesions. Now, this next picture, I can warn you that if we saw this person walking around in the United States, we would probably take her by the hand to the nearest medical facility. But in third world countries, they do not have the penicillin availability that we do. And we've got to remember that even in the first part of the 20th century, we didn't have penicillin. So historically, what would happen is the person would get syphilis. There was really no treatment. Eventually, the bacteria would eat the flesh of the nose, and they would build wax and make a fake nose. So a story down here from the South is women would make their fake noses and then they would sit in front of the fire, and of course their nose would start to melt. So there's these things that come out from the fireplace, and it's called a face shield. For the very first time, I saw that last year whenever we went on a trip to Natchez, Mississippi, and in one of those old antebellum homes, they had the face shield. So I had to educate the tour guide on what that was really for. It was so their nose wouldn't melt off. Anyway, so once it's gone, it's pretty gone. So our goal is to try to get it before it reached this point. Um, Neurosyphilis, ocular syphilis, and otosyphilis. This is probably the most scary thing for our Title 10 sites is to potentially miss this. So always do a review of symptoms when you're a nurse or a provider in the Title 10 site, asking if they have any headaches or eye issues or ringing in the ears or ear problems, because that could signal that the syphilis has gone into the central nervous system. It can, again, it can occur at any stage of syphilis, and then it can mimic, like the altered behavior. It can mimic like a paralysis, like a Bell's palsy. You'll have sensory deficits, and then it can also mimic dementia. In one of our nursing homes, it was found that a older gentleman had a positive syphilis that had never been treated, and he was in the memory unit. We are not sure if it was a cause of the syphilis not being treated or if he actually did have dementia. But once it gets to that point, even though he was treated, the damage to the system is done. Always, if you have a patient that's having these symptoms, always screen for HIV infection, because again, with any kind of immunocompromised state, it can invade that central nervous system much easier. And evaluation and treatment, you must refer to a neurologist, infectious disease, or to the emergency room same day, very, very quickly, in order to preserve the sight and the hearing and the for the patient. Ocular syphilis. This actually happened to me. What had happened was there was a man that came in, immigrant from Haiti, and he comes to the clinic and he's wearing his glasses. So we will go through this, I think, a little bit later. But ocular syphilis, if you ever have somebody that's sensitive to the light or looks like they have conjunctivitis, they have flashing lights, their vision is changed, then always, always test for syphilis. Let's see, evaluation and management is, again, if you have any suspicion, go ahead and refer to an ophthalmologist or to the emergency room. Otosyphilis is where it can attack the nerves of the ears, and you get sensory neural hearing loss. It can either be one-sided or both, and it's usually a sudden onset and progresses rapidly. So it's not something that happens over years. It's usually really fast. Tinnitus is also something like if you have the ringing in the ears or the vertigo, can happen as well. And you'll want to refer these patients to the otolaryngologist, ear, nose, and throat, and the emergency room. I got a question in the chat. Is there a comprehensive list of syphilis symptoms by stage? Yes, the 2021 STI guidelines. I don't want to say it's a comprehensive, but it's most of the time what we see. Like, again, as soon as you think you've got all these symptoms down, somebody's going to present with something that's going to surprise you. Oh, thank you, Heather.
Yeah, look at including some stuff in the chat as we continue.
Yeah, thank you. So any questions about the different stages? No? All right. Well, now we're going to get into diagnostic methods. Okay, so we have something in front of us that might look like something. How do we figure out if it's actually syphilis or not? We're going to talk about two different types of tests. One is non-treponemal and one is treponemal test, and they're a little different in the way that we test. And then we also have different screening algorithms. One is traditional screening algorithms where you start with like the RPR or VDRL, and then it cascades down. And then we have non-traditional screening where you start with the treponema specific test and it cascades down. So we're gonna talk about all of that. This is what I call my serologic alphabet soup. It is sometimes whenever you're working in your Title 10 site and a patient is referred in and they come in with this lab and it's got all of this alphabet, you have no idea what that test is because it's not one that you may use in your clinic. So this might be a handy tool for you to see if that test is a non-treponemal test or whether it is a treponemal test. And we're going to go through the differences in the two here in just a second. My slide moved again. So with non-treponemal tests, I wanna give you an analogy before we go too much further. So I did OB care for about 10 years, and so much of what I think of with the treponemal test and the non-treponemal matches up with the types of pregnancy tests that we have available to us. You know, there's a pregnancy test that you can do in the clinic that says it's got a line, and if it's got a line, you're pregnant, and if it doesn't have a line, you're not. That's a yes or no answer. That is going to be your treponemal. That's going to be your yes, you have, or no, you don't. Then there is the RPR and the VDRL, which is a lot like your HCG quantitative, where if you send it off to the lab, it can give you a number that usually associates with the number of weeks pregnant that that patient is. It doesn't tell you anything just mainly on that first level, but then when you repeat it again, you can see if that level has gone up or down, and that helps to know how that pregnancy is doing. All right, now, so put pregnancy aside, that is what we're talking about with the VDRL and RPR. It is a test that is not treponemal specific, so therefore you can have more things that cause you to get a false positive, such as immune disease like lupus, IV drug use, recent fevers, or pregnancy. Pregnancy can give you a false positive. You can also get false positives if you've had like a recent vaccine. So just because you get a positive VDRL or RPR does not mean that they have syphilis. That means we need to do further testing. So at that point, you would do the specific treponemal test. Now, the advantage to doing the treponemal serologic test is that it's cheap and it's easy, and it also allows for quantifiable results whenever we are watching the titers for treatment. So it is used. It's just you can't make a determination if they have syphilis or not based on just that one test. Oh, here's a list of all of the other things that can cause a biologic false positive. And an example of this would be if your lab comes back and it would be, actually, it wouldn't be this, it would be the VDRL would be reactive and the CIA would be non-reactive. That would be a false positive. So here is a list of all of the different types of treponemal specific tests. I think that you use the CIA in most of your clinics, but you might also use the rapid test. I believe you use the ChemBio HIV syphilis combo test, and that is a treponemal specific test. You're actually testing for the specific antibodies of against the antigens associated with treponemal pallidum. So it's qualitative, so it doesn't give you any titer to say how prominent that load is in the bloodstream. It's just the yes or no question. Once you have syphilis and you have those antibodies, it's usually positive for life. In 95% of all cases, that antibody will stay positive. So you can't just do this test and know that, oh, they have syphilis and they need treatment. Not necessarily, because if they've had syphilis, they've had treatment, it's still going to stay this one is still going to stay positive. That's when you have to look at your titers to see if it's new or if it's an old infection. The advantages of using this one as your primary test is that it's sensitive and specific. You can detect more cases, and it's traditionally used as the confirmatory, but you can also turn that around and use it for screening and then reflex your RPR for your titer. One of the analogies I like to work in here is with the titer staying positive for life is if you can imagine a fish bowl. You know, all kids, I think, have to have a goldfish at one time or another. So you've got the goldfish in the fish bowl, and it's swimming around, and then you pour bleach in that water. What happens to that goldfish? Well, it's gonna die. Okay, but is the DNA of that fish still in that water? Yes, it's still there because we hadn't dipped it out. That is the same way that syphilis antibodies are. Once you get that syphilis in there, then the antibodies are present, and even if you pour the penicillin to it, the antibodies are still going to be there, even though the active bacteria is dead. So that is the difference in how you can't just say, oh, they have syphilis because they have a reactive, CIA. Now you'll never look at a fishbowl the same again. ChemBio HIV combo rapid testing is amazing. I want this for the state of Louisiana. It's one finger stick and it gives you both your HIV and your syphilis test. And it's very highly sensitive for HIV and for the Treponema pallidum antibodies. It's a two-step process done in 10 minutes. It should be used, though, on patients who have never had a positive syphilis IgG in the past. And again, that's because once you are positive, it's going to stay positive. You can also use the DPP micro reader for objective results because, all of our eyes see things differently. So that makes it more objective. And it is reimbursable. For some of you who just have the syphilis health check, this is actually what we use. It's CLIA waived. It is very similar to the other. It's just the one test and it's treponema specific. Okay, I was in the chat. As we go through this, I want you to tell me what your clinic does. Do you do traditional screening for syphilis or do you do non-traditional screening? What do you key in first? Do you key in the RPR or VDRL or do you key in the EIA or CIA? Which one? Traditional is RPR, VDRL, and non-traditional is the EIA or CIA. Here's what we usually have coming into our Title 10 clinics is they may go to the blood bank and try to donate blood. Well, the blood banks down here, not sure about in Montana, but the ones down here are still doing the RPR for syphilis test on the donated blood or plasma. So as we know, there can be false positives with that. So a patient gets all freaked out whenever they call them and say they've got syphilis, and they come to the health unit and they say, we were told we had syphilis, and I'm just going to get a divorce. Well, it's up to us to really then calm them down and explain that can give a false positive. What I'm going to do is I'm going to do the confirmation test, and then let's see what comes up. So that is typically what we have to do. Oh, we already did this poll, so sorry. All right, this is once you understand the way that the syphilis IgG goes up, you see this green line, it goes up and then it stays up. In 95% of all cases, it will stay positive. Now, with the VDRL, I want you to look at it's actually this imaginary line here. You can see this VDRL going up, the yellow, and it goes up, and then eventually it will come down to, most of the time it'll come down to non-reactive when they've been treated, but sometimes it can even come down to non-reactive when they have not been treated. So the statistic is in about 45% of all patients who have not been treated, if you are just screening with the VDRL, 45% of the patients are going to go back to non-reactive, not ever having been treated. So that's why we recommend that we screen with this, the IgG, because you're going to catch all the people that have ever had syphilis, that have been treated, and the ones that haven't been treated. And then you do the research to make sure that they've been treated and that they haven't had a fourfold increase. So that is the way we really do recommend doing it, if at all possible. So again, the reverse screening is where you're looking at the specific antibodies with the CIA. It's automated, it's fast, it's done on a machine, less lab to lab variation. There's also less eye variation, so that's a good thing. But the disadvantages, and the reason why we still have the RPR and VDRL, is because it can't be used to monitor treatment. When you treat and you have that titer, you need to document a fourfold decrease to make sure that your treatment was adequate. All right, let's see. I think I said all that. It takes two. Well, it takes two to get syphilis. It also takes two to diagnose. Two tests, that is. You're going to need the treponema specific, and then you're going to need either the VDRL, RPR to be reactive. If you get one that's saying yes and another one that's saying no, that's when a tiebreaker comes in, usually a TPPA, to either say for sure it's yes or for sure it's no. And this is the way we distinguish between active and inactive syphilis. You can also look at your titers. You got to follow those titers and then see if it's been a fourfold increase that may indicate a patient has been reinfected. The following of the titers is done at 6 and 12 months if it's primary and secondary, and then early and late has 6, 12, and 24 months. If they're HIV infected, because they have a higher risk of developing neurosyphilis, we watch them a little more closely with repeat titers 6, 12, 3, 6, 12, 18, and 24 months. I like this because sometimes you get this patient that comes into your clinic and they look like they have a primary chancre. And I mean, it just looks as classic as it can be. And you get that lab back and it's negative. And you're like, well, how can that be? That takes time. There's a window period between the time that you get infected and may have symptoms before that the antibodies are created. So it may be that with the VDRL and RPR, 60 to 80% of all cases will be positive if they have a lesion. For the CIA, 65 to 90% will be positive. But on the opposite of that, you see how, you know, 10 to, what is that, 35% may be negative, but they still had the primary and you still treated them with the bicillin and they're good. So the reason why we talk about this slide is because sometimes if it looks like a duck and it quacks like a duck, it is a duck regardless of what the lab says. Now, with secondary, because it is a rapid dissemination into the entire body and you have more global symptoms, by then, if that rash is there and their test is negative, it's not syphilis. Okay. With latency, you can see how you can miss some of the patients that don't have symptoms, because if you're just testing with the VDRL, anywhere from 10 to 60% you may miss because that test is going to be negative, whereas only 5% you're going to miss if it's with the CIA. This is a grid that you can print out if you want to. It talks about the interpretation of the test results, but always remember you need two to agree. If you've got a positive or equivocal a syphilis CIA, and then you've got a negative RPR, well, that's incongruent. So then you're going to get that tiebreaker in, and it's going to, whatever two agree is what it usually is. So here you got positive, you've only got one positive here, but you've got two negatives, so it's negative. So see how that works. Whatever two you have is what you go with. All right. And this, she's going to drop in the chat. Look at her. Because I know that this is very hard to see, but it's an algorithm that shows with the rapid workflow, all that you go through and management and labs and all of that. Truly great opportunity to print and laminate. This is a reverse syphilis algorithm where you start off with the CIA, and then depending on what it is, if it's non-reactive, then it's going to be good. You're done. But you cannot rule out early primary syphilis. Like again, if you have an ulcer, go ahead and treat it if it looks like syphilis, because it's possible this could be still non-reactive in that early stage. If it's equivocal, then they're going to repeat the CIA. If it's still equivocal, they're going to go to an RPR, and then depending on what it shows out is what it'll report. When you're looking at this, just real quick, the easy way to look at this is if it's a green test, that means it's reactive. With two greens, you have to stage and treat. With two yellows, that's a question. You're going to have to complete the algorithm to find out. But if it's white, you're good to go. Here is your reverse screening algorithm, where it starts with the treponemal test and the treatment that's involved with it. So you got a red that's reactive, a red that's reactive. With no history, that's when you're going to stage and treat. If you've got the reactive with history, then you look at that last titer. And we're going to get into titers in a second, but a fourfold increase in the titer is clinically significant for a change. So you want to stage and treat if they've had a fourfold increase, because just because they've had it in the past doesn't mean that they can't get it again. Think back to the goldfish. Might have a dead goldfish in there, but if you put another live one in there, you got a live and a dead one, right? So you can get it again. And the way you know is by seeing that fourfold increase. If you have a reactive with a non-reactive, and then it comes back with a second reactive, then you've got two that agree. If you've got two that don't agree, then it's not. All right, and this is the reverse screening treatment algorithm, where if you have it equivocal with a non-reactive, then it flows on down to the TPPA for your tiebreaker. In this case, it's showing you that you have one non-reactive here, one non-reactive here, so syphilis is unlikely. But if you have a possible yes here and a possible yes here, that's when you need to do some further research and consult with your medical director or the STD Clinical Consultation Network. I believe yours is in Washington, if I'm not mistaken. Ours is in Denver. So yeah, they all have that awesome network where you can call and run a case by them. All right, so welcome back, everyone. Now we're going to dive into some syphilis treatment. Again, it depends on how you stage as to how you treat. So let's go through the CDC guidelines for treating in each of the stages. Let's talk about primary and secondary syphilis. This is when they have symptoms. So they either have the genital ulcer indicating primary syphilis, or they have the skin lesions, secondary syphilis with the rash, condyloma lata, the patchy alopecia, all of those things. The treatment is the same. It's going to be the benzathine penicillin G, which is the long-acting penicillin, 2.4 million units IM. And I don't know if what you have in stock, but we have both 1.2 million units, and we have a syringe that's 2.4 million units. So make sure you're looking at your syringe. But if it's 1.2, you're going to give them an IM injection in both sides of their gluteus. Um, a little hint, if they are prone to vasovagal reaction, you may want to lay them down. It is not a pleasant shot to receive. Just a warning there. We've had that happen when they get up to registration to check out, and then they're on the floor. So anyway, allergy to penicillin, as long as they're not pregnant, you can use the doxycycline 100 milligrams twice a day for 14 days. Please make sure that they know that they need to take all of their antibiotic. Understand it's difficult, but it requires all of that 14 days. If they're pregnant, you're going to give the same penicillin as you do to when they don't have an allergy. The difference is if they are pregnant and allergic, you still have to give the penicillin. Well, not us. What we're going to do is we're going to refer for them to get desensitized. And usually what this happens, at least in Louisiana, is we send them to an allergist who then puts them in the ER, loads them up with corticosteroids and Benadryl, and has the crash cart right there on hand. And then they give the penicillin anyway, but they're in an environment where they can manage any kind of allergic reaction. Here is the cascade for the primary or secondary syphilis. When you see the ulceration, skin lesion, if they're allergic to penicillin, then you determine if they're pregnant. If they are, that's when we have to refer for desensitization. If they are not pregnant, that's when they get the doxycycline. If they're not allergic to penicillin, then they get the 2.4 million units for one dose, just one dose. And then always want to test and treat partners. For primary, it's the last 3 months plus the duration of symptoms is the partners we want to test and treat. If it's secondary, it's 6 months plus duration of symptoms. So all the partners they've had in these last time frames. If you can document, again, that window, you can document that they've definitely had a negative within that last year, or they've had a fourfold increase within that last year, then we're going to treat them the same as primary and secondary. So again, it's just one dose of the penicillin G, 2.4 million units, or the 14 days of doxycycline. If they're pregnant, they're going to need to get the penicillin regardless, but we're going to desensitize those that are, or refer for desensitization for those who are allergic. All right. Here is the algorithm for early latent, along with the criteria of what makes an early latent case. Do you see all these 12 months? All hinges on 1 year. So documentation of a negative test within 12 months, or a fourfold increase from their last titer within 12 months. This is in the CDC guidelines, but we really don't go by like a rash if that wasn't diagnosed. So, because rashes can be caused from multiple different things. But it is in the CDC guidelines if they did have a primary or secondary syphilis lesion that within the last 12 months, we can stage them as early. Okay. And again, just go through and determine if they're allergic, if they're pregnant, And then the difference with this is if they have a titer that's positive, then we're going to determine if they're HIV positive or negative, and that tells us when we need to rescreen that titer. The goal is that within a year, that titer decreases by fourfold, but sometimes it takes a full year or longer. But you know that your treatment was adequate when you see that fourfold decrease. If they don't have a titer, like say it's your CIA is reactive, and then you have non-reactive on your RPR, and then your TPPA is reactive, and you can't document any treatment in the past, you go ahead and treat, but there's no titer to follow. So if there's no titer to follow, you don't have to bring them back. All right, this is the late latent syphilis or syphilis of unknown duration. This is where you have a positive lab, but either the documentation of the negative test was more than 12 months ago, or the last titer was more than 12 months ago. So that's the only difference, is that when was that last titer, or did we have a titer? If we didn't have any titers at all, then it's going to be unknown duration, and we're going to follow this algorithm for treatment. In this one, we're going to give the penicillin IM 2.4 million units, but we're going to give it 1 week apart for 3 weeks. A minimum of 7 days with a maximum of 9-day window is between the injections. And what that is for is because the syphilis needs to keep a good um, drug load within the body to treat that bacteria for a certain length of time. So any longer than that 9 days, the drug what is it called? Bioavailability. Gosh, I'm going back to school here. Anyway, it can go down to the point where it's not treating that bacteria anymore. So that's why we have to be pretty rigid with the dosing every 3 weeks. With the doxy, now if I think taking a week of antibiotics is hard, this is 4 weeks of antibiotics twice a day. So make sure that they know that that is required to get the full treatment in. If they're pregnant, they're going to have that 3 consecutive weeks. And again, not only when you're pregnant, you're also treating that baby. The to cross the placental barrier, you have to use penicillin. That way it treats not only the mother, but the fetus as well. And you've got to keep that sustained level of drug in the system in order for it to treat adequately. So minimum of 7 days, maximum of 9. And then refer for desensitization if they are allergic to penicillin and pregnant. Here is your algorithm that you can print and laminate if you'd like. This depends on if they're allergic to penicillin as to which way we go. Heather, for some reason, my yes disappeared again, and I
Yeah,
just pulled these slides. But
we'll have these slides posted to our resource page and we'll make sure that they're updated.
yeah, I'll make sure that these little things have a yes here. But anyway, it also lists the number of days in between the doses for your convenience, so that you don't have to look that back up. This is a beautiful slide that gives a synopsis of all of the different stages and the treatment just at one glance. So, where'd it go? There you go. And also just to know that if you ever suspect any kind of neurosyphilis, which we really haven't gone through yet, please make sure that you don't give them the IM penicillin. The difference is in order for it to cross that blood-brain barrier, you have to have that IV penicillin in order for it to preserve the sight and the hearing and the brain. How many of you, raise your hand if you know we're in a bacillin shortage? Yes, unfortunately. It's looking like the last time we heard from CDC was we're looking at a bacillin shortage at least until the fall of 2024. So where we can, we would like to preserve that bacillin units that you have for the pregnant patients because that's the only thing that works with them. Of course, follow your guidance from Montana Family Planning and your leadership. But there is a website that is at the bottom of this. It's very hard to see, but you can click on it and it's hyperlinked for the latest updates on the FDA drug shortages and the CDC STD drug notices. And we'll make sure that that's visible on your set. For partner notification, all of the sexual partners with a person who has just been diagnosed with syphilis needs to be seen and tested, screened, and also treated as a contact. So we go ahead and give that bacillin, that 1 dose of bacillin to any contact within 3 months plus the duration of symptoms for primary, within 6 months for secondary, and within a year if it's early. So depending on the stages, it all falls to stage appropriately. So not only do you treat correctly, but also the sexual contacts and the time frame is appropriate to you. I'm not sure if you've ever seen a primary syphilitic chancre in the healing stage and also be developing the rash at the same time. If that's the case, then it's considered primary. It's always considered the step up. So if they have the healing chancre with the rash, you're going to diagnose, or not diagnose, you're going to stage that as secondary because that indicates that it has already started to disseminate through the body. All right, for persons exposed through sexual contact with a person who has primary, secondary, or early latent, so we're still talking within that 1 year, always clinically look at them, draw their serology, and then you're going to treat presumptively for early syphilis. And then if the contact was more than 90 days before the diagnosis, we're going to get the serologic test. And if they're not available, then we're going to go ahead and give that 1 dose. If they're negative and we already have that that test, then we don't have to give a dose because we know it's been over the 90 days and the window period is already passed. So if they're positive, they're going to be positive at that point. And then if the serologic tests are positive, of course, you're going to stage and treat based on that that patient themselves. Any questions with partner therapy with the less than 90 days versus over 90? And this goes back to where, remember the slide where I showed you that if they're a primary, you can have a symptom, but the screening test could be negative. This is where that comes in. Then less than 90 days, they can have a negative test when they really do have it brewing in there. That's the problem. Populations with high syphilis infection rates, we need to notify and the notification and presumptive treatment of sex partners of persons with syphilis of unknown duration who have the high non-treponemal serologic test titers, like over 1 to 32, may indicate early syphilis. These partners should be managed as if the index patient and just have early syphilis. The sex partners of persons who have late latent should be evaluated clinically and serologically for syphilis, and based on their treatment is based on their own individual findings. Let's talk about persons with HIV. The interpretation of the test is the same if a person is living with HIV versus if they're not. But with HIV, sometimes you can get some unusual serologic responses. For instance, it may take longer for the fourfold decrease to occur if a person is living with HIV. You can also get some false negative test results. You can get clinical findings that look like syphilis, but yet the tests are non-reactive. We're still going to treat. If it looks like syphilis, go ahead and treat. And then neurosyphilis, ocular syphilis, and otosyphilis should be considered among any person with HIV because it's so much easier to enter that central nervous system with that client population. And because of their immunocompromised state, we do want to watch their titers more frequently. So we're going to rescreen their titer at 3, 6, 9, 12, 24 months, just to make sure. It might not go down fourfold in a year, but we do want to make sure that it is coming down and not staying the same or going up. Special circumstances regarding syphilis in pregnancy. As you saw with those statistics in the very beginning of the presentation, if you have a high rate of primary and secondary syphilis in women of childbearing age, what are you going to also have? Higher rates of syphilis in pregnancy and congenital syphilis. You can see where both of those were rising at the same levels. This is 100% preventable. And it can be very devastating with a pregnancy. It is recommended that we screen at the positive UPT for syphilis, the first prenatal care visit, at 28 weeks, and at delivery. What can happen, and I'm not sure if this happens in Montana, but in Louisiana, we have one of the worst perinatal mortality and morbidity rates in the nation, and we have a lot of women who are a lot of provider deserts where they can't get to a provider because it's so rural. Well, what'll happen is a woman may come in for her initial OB visit. She may find out she has syphilis. They give the first injection, but then if she doesn't complete the other two, if it's required, if it's latent syphilis, if she doesn't finish the other two, and it's been beyond that 9 days, she has to come in and start the series all over again. And so this just it's a never-ending battle. And so then the patient may escape from care and be lost in the system. They present then to deliver having not been fully treated with their total 3 doses given at every 7 days. I will tell you in the CDC guidelines, it is pretty rigid that doses must be given every 7 days for 3 consecutive weeks. Usually the window is given though because that's very hard for women to get right at 7 days. So a window is given for 7 to 9 days. But if they are 1 day past that 9 day, they got to restart that series. Any questions about the pregnancy or anything we've discussed so far? Okay, cool. Well, titers always really I never really understood titers. And so until I came into this position and I really had to dig in a little bit. I want to explain how the titers are done in the lab, and then you can understand, I think, more of the disease process of what's going on in the body. So once the lab gets a specimen for a titer, they spin it down to the serum, and then they take a drop of the serum and they put it on, say, a card. It almost looks like a newborn screening card, but it's got these little round wells, and you put that in there, and then you put some buffer solution in there, and you just stir it a little bit, and if it clumps together, this is the Tammy explanation. If it clumps together, that is reactive. If it's reactive in that well, they take a drop from that well, put it in the next well, add another drop of buffer solution to dilute it a little more, stir it around. If it clumps, it's still reactive. And they continue that process until it stops clumping. When it stops clumping, that is the titer. So you can see where this is like the first well, and then they take this one to this one, and every time it is it doubles this. So you can multiply this times 4. Um, well, except for this one. 1 to 1 is a 1 to 2, and then it goes, you multiply that times 2, and you get 4, and then you multiply it times 2, and you get 8. I'm sorry, I said 4. You multiply it times 2, and you get the next titer. So the very next one, if you take 1 to 32, multiply times 2, what are you going to get? A 1 to 64. Yeah, I saw somebody's lips move. Yay. Melissa, great job. 1 to 64 is going to be your next step. And I have seen this go into the thousands. Now, again, I go back to my analogy with the pregnancy test. What does this mean? Well, I mean, if you've got this titer and you've got a positive, a reactive CIA, then, well, you know you're dealing with syphilis. Great. But it really doesn't tell you a whole lot until you repeat that titer and compare it to the last one to see if it's going up or see if it's coming down. So that is where we're looking at the titers. We're looking for a 4-fold change, which is clinically significant. A 4-fold, you can think of it like taking this number and multiplying times 4, or you can just print this out and move it 2 decimal spaces, which is like, that's kind of the easy way. But always multiply times 4 or divide by 4, depending on if you're wanting to go down the slide or you're wanting to go up, or you're seeing if it went up by 4-fold. So let's say that a patient comes in and they have a 1 to 64, and we treat them with their appropriate treatment. Let's say it's early latent. They get 1 dose of bicillin. They come back in 6 months. And their titer is 1 to 16. Has that been a 4-fold decrease? You can look at, yeah, you can see there's a 2-fold and there's a 4-fold. You can take 64 and divide it by 4, and as long as it's 1 to 16 or less, you've already got your 4-fold decrease. You're good. Again, it may take a year for that to happen. So as long as it's not rising or staying the same, you should be fine. That means our treatment is working. Monitoring the success of treatment is, again, you repeat the titers. Your goal is to have that 4-fold decrease within 12 months. Remember, sometimes with persons with HIV, it may take longer than 12 months, but just call your regional medical director and run that case by them at that point. Evaluate for a treatment failure if the titer does not decrease 4-fold in 12 months. It could be that they need to be retreated, and or it could be that it's just taking them a little longer. It could be that they've gotten reinfected. So just run that by your medical director as well. The response to the treatment is associated with certain criteria. So we know that earlier stages are more likely to see that decrease faster than those who are in the later stages. And then if the initial titer is less than 1 to 8, it may take longer to have that 4-fold decrease because just of the amount that's in the blood. I think it's just lovely whenever I get a very high titer and you repeat it in 3 or 6 months and it's all the way back down to 1 to 4. Well, it doesn't really matter if it's 1 to 4 or 1 to 64. The goal is to have it decrease by 4-fold. Do you see what I'm talking about? It's great. Hey, that's a no-brainer. We know that that's 4-fold decrease. I don't have to do math for that one. But as long as it's 4-fold, we're sitting good. Again, in 85 to 90% of patients, it usually drops to a non-reactive titer after treatment. But is 10 to 15% of patients that are going to continue to have a low titer no matter what. That doesn't mean they need to be retreated. It doesn't mean that they have gotten syphilis again. It means that they are considered serofast, which is where they will have a CIA that's reactive. They'll have a RPR or VDRL that's like 1-to-1. You'll pull their last history and it's been a 1-to-1. So there's not been a fourfold increase, so they do not need retreating. They're just going to kind of hover at that low titer, but that does not mean that they need to be retreated. As long as they've had that fourfold decrease and it hasn't gone up, fourfold, we're good. This is an example of 6 months ago, a client came in for secondary syphilis and was given bicillin 2.4 million units times 1 dose. So anytime I see a history, the first thing I want to know is what stage were they and what medication were they given. What I'm making sure of is that the stage and the treatment match. Sometimes people don't come back, like for late latent, they may need 3 shots, but they only got 2, which means that they were not adequately treated a year ago, so they need to be adequately treated now. With secondary syphilis, the correct treatment is 1 dose of 2.4, so they were correctly treated. That's great. So then here's our lab 6 months ago. It's reactive with a VDRL of 256, 1 to 256. Today, 6 months later, we got reactive. And remember, this one's probably going to stay reactive. In 95% of all cases, it stays reactive. And then a VDRL of 1 to 8. Do we have a fourfold decrease? You can just shake your head, give me a thumbs up, thumbs down. Yep, that's right. So it was here. You can take 256 divided by 4, or you can just move it down 2 decimal places. So as long as it's a 1 to 64 or lower, we are good. And so you can tell that we have a successful treatment. How do you know if it's a treatment failure versus a reinfection? This is a good question. And this is why I like syphilis so much, because sometimes it's a puzzle that you have to put together. It's not a one and done. So you have to look at the history. You have to look at your labs. And I want you to think reinfection. If they have no neurologic symptoms, so no headache, no eye complaints, no ear complaints, they're continuing to be sexually active, then you want to repeat the syphilis treatment because it's probably a reinfection. Okay. Think treatment failure if they have any type of neurologic symptoms, which would indicate that it's in the central nervous system, and the IM version of the penicillin won't work for that. So you would need to check for neurosyphilis and then make sure that they get the IV penicillin for that case. If they have not had any reported sexual behavior or reported sexual exposure during the last 3 to 6 months, but yet they're still having the high titer, you might want to think about treatment failure. And then also suspect treatment failure. Anytime you suspect treatment failure, refer to a infectious disease or ER doc so that they can do a lumbar puncture and test for syphilis in the CSF fluid. Always rescreen for HIV. Even if they were negative before, rescreen for HIV if you suspect that happening. For treatment failure or reinfection, again, you should see that fourfold decrease by 1 year. So if you don't see that fourfold decrease, that's when you're going to need to look at, is it treatment failure? Is it reinfection? Or are they just taking a little longer to get down to where they need? And again, don't forget the STD clinical consultation network that is at your disposal. All right. Any questions before we get into the fun stuff? This is where I'm hoping it's all going to come together. So let's start with a 20-year-old male who comes into the clinic with a rash on the bottom of his feet that began a week ago. His sexual history, his partners are women. He's had 5 partners in the last 6 months, 10 in the last 12 months, inconsistent condom use, and was told he was exposed to syphilis. On his exam, you see the rash on the bottom of the feet, palms of the hands, and the lower torso. So let me get you to answer. All right, so let's look at this together. With this exam, what stage of syphilis are we talking about? Absolutely 100%. Y'all got it right. Secondary syphilis. Yay. Now, what if the exam revealed a penile ulcer 100%? It's primary syphilis. Okay. What if had both the healing ulcer and the rash? You got it. Secondary syphilis. Perfect. Very good. Let's go on to case study number 2. 35-year-old female comes in for her annual exam, and she gets a refill on her Depo-Provera for her contraceptive method. She's asymptomatic, and I'm going to give you a hint. When I say asymptomatic, what does that rule out? Primary and secondary. You can't have primary and secondary and be asymptomatic. Okay, so I gave you a hint. PAP was done, STI testing, and then the labs return, and you've got negative, negative, but then on syphilis, you've got reactive, non-reactive, reactive. I want to show you how my brain works. What happens is I look at the lab results. When you've got this one and this one agree, you know you're dealing with syphilis in some form or fashion. So you know it's not a biologic false positive. So we're dealing with syphilis. Now we have to figure out, is it new syphilis or is it old treated syphilis? Okay, so now let's launch this poll. There's 4 questions on this one. Based on the labs and the exam history, what is your next steps? Well, you have to know, because you know it's syphilis in some form or fashion, but you don't know if they were ever treated in the past, you really need to contact your health department or your disease intervention specialist, if you call them that, for a record search. And so what they're going to do is they're going to pull any records like the past history, the treatment, your past labs, and just make sure that that they were staged and treated in the past, and that they haven't had a 4-fold increase in their titer, which we know they haven't because it is non-reactive. So the DIS comes back and says, okay, they had a negative 6 months ago. We're within that 1-year window. We know it's early latent. We know they're going to get 1 dose of the bacillin. But if they come back and they say that the last lab was 13 months ago, you can see where that goes from that 1-year period to the more than 1 year. And then you're going to stage as late latent. And that changes the treatment from 1 dose to now 3 doses. The next one, this is the guy who came to see me. He is the 32-year-old from Haiti. He was referred for a positive syphilis test. He had his eyeglasses on, and when I asked him to remove them, he had right eye pain, decreased vision, and photophobia. And actually, one pupil was non-reactive, and he had iritis. What are we going to do? we're definitely going to draw the lab just so we have it in our system. Dim the lights for comfort. We don't want him to suffer. But giving the bicillin IM is the incorrect move because he could think, oh, good, I'm treated, I'm good to go, when he could actually lose his sight because the IM is not going to work for neurosyphilis when the eye is involved. And yes, you would call your medical director or send him to the ER immediately. Very good. Um, yes. And so the end of the story was we sent him to the ER. He had a lumbar puncture by the infectious disease specialist. He did have a VDRL in his CSF fluid of 1 to 8. He was treated with IV penicillin and retained his vision. Yay, success story. All right. Case study 4 is a female that comes in with a positive UPT in the clinic. She was treated for secondary syphilis 2 years ago with bicillin times 1. All right, right there. Is that the appropriate treatment for secondary syphilis? 1 dose of 2.4. Yes. Very good. So we're good there. Keep going. Labs 2 years ago were reactive and 1 to 32. So she comes in today and she's got reactive, non-reactive, reactive. All right. The first thing, look at these labs. Are we dealing with syphilis in some form or fashion? Do we have 2 that agree? So yes. Now, is it active or is it dead? Look at your past labs. We've got a 1 to 32, and now we have non-reactive. Is this a 4-fold decrease? Yes. Does this person need retreated? No. Are y'all getting that? Y'all seeing? Give me a thumbs up if y'all are good. Okay. Awesome. I saw it. All right. We're going to skip forward. I know we're running out of time. I want to make sure you have plenty of time for questions. Case study 5 is a female comes in for STI testing, has a new sexual partner with inconsistent condom use. Exam was normal. So exam normal, I just said that it can't be 2 stages, right? Labs return and it's reactive, non-reactive, reactive. Are we dealing with syphilis in some form or fashion? Yes. Okay. Is it live or dead? How do we know? We got to consult DIS or our state health department, right? And they're going to give us all the answers to this puzzle that we need. Either they're going to have something or they're not going to have something. So when it comes back, all right. Yes, this is syphilis in some form or fashion. And then if there's no past history, we're dealing with a SUD, syphilis of unknown duration, in which they're going to get the full 3 doses 1 week apart. Perfect. Excellent job. Case study 6 is a 32-year-old MSM presents to clinic with a painless penile ulcer. We gave him 2.4 million units IM the same day, and then his labs return in a few days showing reactive and 1 to 32. Right. Yes, it's syphilis, and you're going to give that 1 dose, which was already given in clinic. The only follow-up would be that you need to call him and make sure that he knows that all of his partners in the last 3 months need to come in for screening and contact protocol. And the other thing is, let's say he's HIV negative. When are we going to see him back? A 49-year-old comes in with tinea versus psoriasis, and then also has vitiligo of the glands, but no sores, no rashes, no other symptoms. Um, then reactive, non-reactive, reactive on his labs. The DIS history, he said he's been treated for primary syphilis in 2000 with bacillin times 1 dose. Is this the correct treatment for primary syphilis? Yes, the 1 dose. That's good. All right, now look at this titer, 1 to 16. Divide 16 by 4. Did he have a 4-fold decrease in his titer? Does he need retreated? Yes or no? You are right. Excellent. Very good. Is it kind of starting to come together a little bit? Okay. It's a puzzle. I know. 28-year-old comes in and has reactive, negative, reactive. So is this syphilis in some form or fashion? Yes. All right. We get the DIS report, and it says he was treated for late latent in 2001 with bacillin times 3, which is the correct dose for our treatment for late latent. And his last titer is 1 to 8. Did this go down 4-fold? Does he need retreated? No. Good. All right, here's common. 42-year-old comes to the clinic and has the annual exam. Her labs come back reactive, negative, reactive. Is this syphilis or a biologic false positive? Syphilis, yes, in some form or fashion. Then we get the DI's report and there's nothing. So what stage is this going to be? I'm trying to read lips. Syphilis of unknown duration, right? Because we can't say it was within a year. We can't say it was, I mean, no history at all means it's unknown duration. So anyway, we're going to give him 3 doses 1 week apart, or her. Okay. 24-year-old comes to clinic with a rash on the abdomen and the hands. The testing was done and we went ahead and gave her the bacillin 2.4 times 1 dose that same day. Her labs come back. Was it syphilis? Was syphilis what was causing that rash? Yes. And this is primary or secondary syphilis? Secondary syphilis. And was this the correct treatment that was already given? Do we need any more doses? Nope. So you're good. You've already treated. And so if this is a person with HIV, a person living with HIV, then when are we going to bring them back to repeat this titer? That's correct. 3 months. Very good. All right. Here's a 35-year-old with a penile ulcer for 2 weeks, treated for primary syphilis the same day. Labs come back reactive 1 to 64. Almost the same thing, just a different stage. What stage is this? Primary. Correct treatment. There's our labs. It was definitely syphilis. Now, even if this was non-reactive, if you see that penile ulcer, you can still have an early syphilis and it just not be showing up yet. So don't think that your eyes misfooled you. It may just be that the lab hasn't caught up to what your eyes saw. Okay, 4-fold decrease. Let's say this person is a person without HIV. You're going to repeat it in 6 months. It should be a 4-fold decrease. What is a 4-fold decrease? Divide this by 4 and tell me what it is. Yes, 1 to 16. So as long as it's a 1 to 16 or less, we are good. Here is I think we just got a couple more of these, if I'm not mistaken. 20-year-old comes in for a refill on her birth control. We do routine screening, and she has a reactive, non-reactive, reactive. And then we call in our DIS and no history of syphilis. What stage is this? SUD, syphilis of unknown duration, because if we don't have any labs at all to base it on, we know it's syphilis here because we've got 2 saying yes, but we don't have history. So we're going to stage as syphilis of unknown duration. And how many shots do they get? 1 or 3? 3. Excellent. Excellent. 3 shots, 1 week apart. STI screening due to this new sexual partner, equivocal, non-reactive, reactive. Now, I don't know if I made this plain, but any equivocal, we go ahead and treat like it is a reactive because it could be just an early. So let's say that that's reactive, non-reactive, reactive. Are we dealing with syphilis? Yes. Yeah. And then no history. So it's going to be staged as syphilis of unknown duration. And how many shots? 1 or 3? 3. You got it. Annual exam. We did the screening and it comes back reactive 1 to 64. And then we have the DIS that comes back no symptoms that we saw on exam, but it might be a chancre hiding up near the cervix. If we didn't see it, we didn't see it, right? So DIS report comes back and says that the last syphilis test was negative 4 months ago. So what stage are we in? Early. Very good. And do we get 1 shot of penicillin or 3? Yes. Great job. I think this is the last one. We've got a 25-year-old who comes in. She's seen by the nurse practitioner and treated for trichomoniasis the same day. Her labs come back and it's reactive, non-reactive, non-reactive. What's this? No syphilis, right? It can happen. It can happen. The way I remember that 2 must agree is if you've ever had a 2-year-old that didn't get their way and they go to mama and she says, no, I don't think so. And then he goes to dad and dad says yes, then who gets the determining vote? Grandma, right? This is the way I think about it. Reactive, so one parent saying yes, the other parent saying no, grandma's going to have the tiebreaker. Okay? So whatever grandma says is what gets done. All right. Oh, let's see, there's one more. So routine screening, equivocal, non-reactive, reactive. Remember, anything with equivocal, we're going to just replace that in our brain with reactive. It's better to err with the rates we have in syphilis. It's better to err on the safe side and go ahead and treat versus not. So you've got 2 that's saying yes, then you're going to go ahead and stage and treat. No history is syphilis of unknown duration, and 1 or 3? Yes, I think you've got it. 3 injections, 1 week apart. These are our references, and you will get the slides after this. Do you have any questions for me or anything that maybe wasn't clear you'd like to review?
I have just a curious question. When when you ask your disease intervention specialist at the health department, when they start investigating this, are they able to see testing from other states? Do state health departments link at all?
So that is a great question. I know that our PRISM does link with other states. I wish it linked with all states, but it doesn't. But I think that ours links with the bottom half of the state. And I know that we're not linked with yours because it's Midas, and Ours is Prism. But the good news is that DIS share information from state to state. So if you do happen to know, say that one of your patients came down to New Orleans, they can call our DIS and they can get that lab and treatment information from us, and then use it there in their state. So they do have contact information for others, but it might just not be in the same platform, unfortunately. Good
Just
question,
to
though.
let you know, I do work for the state. I'm the STD nurse consultant, and we do not link with other states. But yeah, if you ever do need a history from another state, let us know, and we can request records and get that information.
Good to know. Thank you, Melissa.
Yeah,
You deal with this all the time, don't you?
I do. Yeah.
And what is the prevalence of treatment failure? I will be honest with you, in my practice, I see more of reinfection than treatment failure. Um, and usually once we retreat and we treat that partner, then we'll start seeing the titers go down. I can't really tell you the prevalence of treatment failure versus the other because it really depends on your client population, but just always know that if they say that they've not been sexually active, or if they have any kind of neurological symptoms, they need a further workup to make sure it's not neurosyphilis. Any other questions? Y'all been wonderful. Thank you for being so attentive and and good at charades, because I love having the camera on. I can see your faces and read lips. So thank you for all of that. Um, I want to do one thing before we leave, and I want to re-ask, how comfortable are you now with syphilis staging? I am so excited, y'all. I'm going to say this is a win. Look, very comfortable, and one neutral. And for anybody who is out there that is still a little uncomfortable, that just doesn't want to tell me, um, always know you have a friend that you can always call. It's called Phone a Friend, and that is your STD clinician network. That's your regional medical director. You can also hey, let me know. I'll help you solve a puzzle. So this is something I love to do. All right.
Yeah,
Stop.
thanks, Samson. Thanks everyone for participating today. Just a friendly reminder, the link to the evaluation is in the chat. Please complete that for your certificate, and especially if you're looking for nursing contact hours. And then just a reminder too, as part of our clinical and training technical assistance this year to you all, and including this presentation, we're also working on a toolkit. So all of the documents I included into the chat today will be included in that toolkit. And once it's available, we will let you all know and include that on our MFP resource page. So that is to come. So thank you all again. We've enjoyed having you. I hope you all have a lovely rest of your day.
Bye, everyone.